Let me introduce Prof. Goh to you. Prof. Goh is currently the head of the Pediatric Allergy Services and senior consultant of the Respiratory Medicine Service at the Department of Pediatrics at KK Hospital, Singapore. Her job scope encompasses seeing both allergy and respiratory related diseases. She developed the bronchoscopy service for the Respiratory Medicine Service. She actively participates in the training of residents and medical students in her work. She is also a member of many professional committees. Amongst them includes things like the Clinical Advisory Panel for Rehabilitation, Committee for Development of Acute Viral Bronchiolitis Clinical Pathway, and the Committee for the Respiratory Tract Infections Antibiotic Guidelines. Dr. Goh is a reviewer of several journals, and that's quite a lot. Amongst them includes the Asian Cardiovascular and Thoracic Annals, the Clinical and Developmental Immunology, Clinical Experimental Allergies, and many, many others. She is also Adjunct Associate Professor of the Duke NUS Graduate Medical School and the Lee Kong Chian School of Medicine. She is Senior Lecturer with the Yong Lu Lin School of Medicine. With clinical and research interests in the area including respiratory infections, bronchial asthma management, obstructive sleep apnea, and allergy. Dr. Goh has authored or co-authored several peer-review papers, as well as given many presentations at national and international courses and conferences. She is also actively involved in many asthma-related infectious disease and allergy clinical trials. So without further ado, I would like to welcome Prof. Goh to give us this talk on antimicrobial resistance and the need for a novel approach to the management of acute respiratory tract infection.
Thank you, Wing Tai, for that review of myself, and I just thank you for being so kind in that. I would like to also thank Shrabi for inviting me to give this talk on the antimicrobial resistance and the need for a novel approach to the management of acute respiratory tract infection. As you all know, acute respiratory tract infections, particularly the upper respiratory tract infections, is very, very common, especially when you're dealing with children. It's the commonest acute illness that is being seen in the outpatient setting. A lot of the children come to you with complaints of fever, cough, runny nose, sore throat, and these are usually caused by the common cold of pharyngeal tonsillitis. Majority of these infections are caused by viruses, and we know that most of these viral infections are self-limiting, though some can be potentially life-threatening. But that is also one of the diseases where the greatest use of antibiotics are given, right? If you look at how many children receive antibiotics for acute respiratory tract infections, it is a great number. So if you look at the common cold, which we know affect children very commonly, that's why it's called the common cold. Many children get an acute respiratory tract infection occurring about 7 to 8 times in a year. Most of them just get a fever, cough, and a runny nose, sometimes with sore throat, and over the next few days, they do get better. More than 90% of the time, it is caused by a virus, and the commonest virus being implicated for the common cold is the human rhinovirus. It is self-limiting. There's no specific treatment for it, so the treatment is totally symptomatic, and yet in many of these children, 40 to 60% of them, antibiotics are given. And we know this is probably one area where the greatest abuse of antibiotics is, because we know it is viral. And so therefore it will get better on its own, and there's no need for antibiotics because antibiotics do not work against viral infections. The other area that is very commonly diagnosed, obviously, is tonsillopharyngitis. All right, and again, in many of these children, the etiology is viral. They always usually get the runny nose and cough and fever together with the sore throat. They all start with those symptoms. And some of them may go on to develop discrete ulcers. They can get conjunctivitis. And if you have these group of symptoms with the sore throat or the pharyngitis, then it's still most likely a viral cause. And the viral infections that can cause it can be due to influenza, para-influenza, and we do know EBV can cause it, and then that can also give rise to exudates over the tonsils. So it does not mean, therefore, that if you see a pharyngitis or even a tonsillitis, that antibiotics need to be given. This is one area where when we did a survey many years ago, asking parents when they're most likely to get an antibiotic. And invariably, one of the symptoms where most of them do get prescribed an antibiotic is when the doctor diagnoses the child to have a pharyngitis or pharyngeal tonsillitis. Okay, but do bear in mind that the majority of these are probably still viral, particularly if you see ulcers or if the child also has rhinitis or rhinorrhea together with the pharyngitis. So it's most likely viral. Okay, antibiotics is only indicated if it's for group A streptococcal infection, and that's what we always worry about, right? Are we missing a group A streptococcal infection, and therefore that can progress to give rise to rheumatic fever and the complications thereafter. However, if you look at the symptoms for group A streptococcal infection, the classical symptoms and signs are the acute sore throat with fever, patchy exudates over the tonsils, and they can get tender cervical lymph nodes. They don't usually get a severe cough or rhinitis with their symptoms. Okay, so therefore, if the child presents with cough, runny nose, fever, and a sore throat, then it's less likely going to be group A streptococcal infection. You do have time to take a throat swab or do a rapid antigen test. Even if you do not end up doing that, if the fever settles within the next few days, then again, it's less likely going to be a streptococcal infection. All right, so you do have up to 10 days to make that diagnosis, and you will still, if you give the antibiotics within that 10 days, you can still prevent the onset of rheumatic fever. So there is some leeway for making the diagnosis of a group A streptococcal infection of the pharynx. Treatment, as you know, is with either penicillin V or amoxicillin, and if they are allergic to penicillins, you can give macrolides, though more and more, many of these streptococcal infections are becoming macrolide resistant. And that is why we really do need to be so careful about how we prescribe antibiotics. Now, if you look at the symptoms between an acute common cold, respiratory tract infection, and influenza, which again can give rise to a little bit more severe disease, then one of the differences you will find that in influenza, the fever, the systemic symptoms of malaise, fatigue, and myalgia are very common, whereas they do not get so much of the nasal congestion and the sneezing. Okay, whereas with the common cold, because it's called the common cold, then you find the rhinorrhea becomes a much more prominent symptom, and they can get sore throat quite frequently with the common cold as well. But in most of these children with the common cold, then the malaise and fatigue symptoms are usually less prominent as compared to influenza. And most of them will get better within the next few days, though symptoms can be prolonged in some of these children up to about 14 days. We know that the viral infections are so common, and therefore they pose a huge burden. And this is just acute respiratory infection attendances at polyclinic. And you can see that in a week, on average, the polyclinics see about 3,000 cases for acute respiratory infection. So it's a huge burden. It's not a small number of patients that attend the polyclinic for an acute respiratory infection. And that's just polyclinics. I'm sure if you add all the GPs and the pediatricians that are attending this, as well as the acute emergency services, then you will find that the numbers go up even more. So it is a very, very common condition. If we look at the burden of community-managed acute respiratory infections just within the first 2 years of life in this study where they followed up just 154 babies, okay? And you find that in the first 2 years of their lives, of this 154 babies, they had as many as 1,650 acute respiratory infection episodes. So one child has many, many episodes of acute respiratory infection just within the first 2 years of their lives. And you can see in this graph here, and this was done in Brisbane, that the majority of these infections are upper respiratory tract infections. Very, very few are actually lower respiratory tract infections. Okay, so again, you know, many of these episodes are going to be viral. And yet, in about 20% of these children, antibiotics were given to these infants. We do know, if you look at this chart, that the incidence of acute respiratory infections actually increased quite a bit from 6 months of age onwards. And what they found was that a major risk factor for developing an acute respiratory infection was when the children started going to childcare. And we know more and more in busy urban countries like Singapore, many children start going to infant care from a very young age. And as early as 6 months, many of them are attending infant care. And you therefore see this increase in acute respiratory infections occurring from a very young age. Is it the majority of these infections are caused by the human rhinovirus, because that's the virus that causes the common cold? And this is a study from Buenos Aires looking at children less than 5 years of age who presented to an emergency room, and with acute respiratory infections, or even in community clinics, and you find that as many as 40% of these children who had human rhinovirus isolated end up being hospitalized for a rhinovirus infection. Okay, and if you look at all the respiratory infections, a huge number of them, as you can see from this chart, rhinovirus was really a very common cause of infection, starting from a very young age all the way to the older children at 5 years. Okay, and the other huge source of viral infections is from the respiratory syncytial virus, or RSV. So these two viruses contribute to a huge burden of acute respiratory infections. Okay. And even though rhinovirus infections do tend to be relatively mild, it's not always so, as we can see that many of these children ended up being admitted as well. This study from the US looked at children aged 4 to 7 years with upper respiratory tract infections. And again, what they found was that human rhinovirus was one of the main causes of an upper respiratory tract infection. The main types that cause disease in children were type A and C, very similar to the ones that trigger off asthma exacerbations as well. Most of the viruses that we see that cause a respiratory tract infection do have a seasonal variation. And you know that we are going into the end of the year, and that's also the period where you see a lot more influenza for Singapore because of the northern hemisphere winter, and we also see influenza in the middle of the year because of the southern hemisphere winter, right? But in temperate climates, these seasonal variations are more obvious because winter is when you see more influenza as well as more RSV. Because we are in the tropics, we see less of this variation, but even in the temperate climates, you find that human rhinovirus occurs throughout the year. Okay, so there is no season for rhinovirus. Influenza is the other big virus that causes severe acute respiratory tract infections. We do recommend now that we are going into influenza season for the Northern Hemisphere influenza season that we get most of our children vaccinated so that that reduces the severity of the influenza. And this study from Australia basically showed that even healthy children can get severe influenza infections. And most of the children that ended up being hospitalized for influenza were actually normal, healthy children. They did not have underlying medical conditions. Okay, so it's good to prevent it rather than to allow them to catch the infection. So we know since respiratory viruses cause such a huge burden of disease, do we have good treatments for it? What do we have for the common cold? Unfortunately, we don't really have good treatments. Most of the treatments are symptomatic. And if you look at a Cochrane review that looked at over-the-counter medications for acute cough in children, and they reviewed the use of antitussives, mucolytics, antihistamine decongestant combinations, or antihistamines. Basically, at the end of the day, what they concluded that there was no good evidence for or against the effectiveness of these medications in acute cough. So many times it is self-limiting. Whatever we give probably does not change the course of the illness or the duration of the symptoms, but we are hoping that it makes the child a bit more comfortable. And if you look at the use of cough and cold medicines, this was a study conducted in US children over an 8-year period, you will find again that a majority of these medicines are being prescribed to young children. It's children below the age of 5. And that's not surprising because that's the age group that also is at higher risk of getting frequent acute respiratory tract infections. So it's the young children with frequent infections that are frequently being prescribed these medications. Then what about antibiotics if symptomatic treatment doesn't seem to make a difference? Will giving antibiotics hasten recovery? And that's what many parents tend to believe. So this was a prospective study that was conducted in Italy, looking at URTI-related acute cough and the use of antibiotics versus antitussive drugs. And these children were randomized to receive either antibiotics, antibiotics with antitussives, or just antitussives alone. And you can see from this chart that really the majority of the children got better, whether they were given antibiotics or not. In fact, the group that did not receive antibiotics appeared to do much better than the group that received antibiotics. Okay, so that may be one reason not to give antibiotics rather than to give. So the symptomatic treatment alone was good enough for most of these children in terms of resolution of their symptoms. This was a study from the UK, which was recently published just in the BMJ last year. And they did a cross-sectional survey on antibiotic use in primary care. And what they found was that there was a high inappropriate use of antibiotics in 25% of these children. And in 18%, they could not find what the indication for the antibiotics was. Okay, so you can see that almost a third of these patients who received antibiotics probably never needed to receive antibiotics in the first place. And what was of concern was that in many of these children, there was an inappropriate use of quinolones, which are very broad spectrum antibiotics. So again, be very careful of your choice of antibiotics. We will really want to use narrow spectrum antibiotics most of the time rather than to use broad spectrum antibiotics, because this is what's going to drive resistance more. So the question then comes, why do physicians prescribe antibiotics for an upper respiratory tract infection? Because we still do see it happening. It's happening all over the world. It's not just a problem in Singapore, right? And many of the physicians will probably say that the parents expect it, and I think that's probably the most common reason given, that parental expectations for antibiotic prescription makes them prescribe antibiotics. Some may believe antibiotics will hasten recovery, or they're worried about complications and progression to a lower respiratory tract infection. So maybe giving an antibiotic will reduce the progression to a lower respiratory tract infection. So let's look at the evidence for this. So antibiotics indicated for an upper respiratory tract infection, there's many studies that have been done encompassing on more than 1,700 children, and this was 6 randomized controlled placebo-controlled clinical trial in children less than 12 years of age. Clinical outcomes were not improved with antibiotics. So again, there's probably no good reason, and I've showed you one from Italy. 4 trials involving 1,300 children aged 2 to 5 years, and again you see that ampicillin given compared to supportive care to prevent pneumonia, progression to a lower respiratory tract infection was no different. A relative risk of 1, which means no difference between antibiotic or supportive care. So at the conclusion, therefore, there was no known benefit with antibiotics given for an upper respiratory tract infection to hasten recovery or to prevent progression to a lower respiratory tract infection. Another indication that some parents do mention is that they complain that the child's secretions are yellowish or looks greenish yellow, and this coloration of the nasal discharge or the sputum is not really an indication for antibiotics, because many of the children with just a simple viral infection, if you look at the nasal discharge, it will change color over the course of the illness. It usually tends to go from whitish to a yellowish, sometimes greenish, and then it will become clear. So over the course of the illness, you might find the nasal secretions changing color. It does not mean that it's always a bacterial infection that's occurring when the secretions change color. It just reflects sometimes the load of cells in the secretions, which gives it that discoloration. So the question, does antibiotics shorten the course and prevent development of pneumonia? Again, many trials have looked at this, involving children from 0 to 13 years or 0 to 12 years. In fact, there were 10 randomized control trials looking at high-risk children, such as those with cystic fibrosis or HIV, or very low birth weight neonates. And all these trials basically concluded that antibiotics did not alter the clinical course, did not reduce complication rates, did not prevent progression to pneumonia, and even these high-risk children, it did not do any of these or reduce admissions or mortality. So at the end of the day, for an acute upper respiratory tract infection, be judicious about the use of antibiotics. So the main reason usually given is parental expectations of through antibiotic, that patient is very likely to receive it. So it's a 10 times more likelihood of receiving an antibiotic if the physician perceives that the parent expects the medication. And we found this as well when we did a parental survey about antibiotic use. And many of these parents said that if they wanted an antibiotic, the physician would definitely give it. Okay, so there's very little, in that sense, communication in trying to explain to parents what a viral infection is and what a viral bacterial infection is. And you find very often parents have no great understanding that antibiotics will not work for viral infections. So that is what comes of the misunderstanding between parents and clinicians when they're talking about the severity of the illness and when we are explaining between viral and bacterial infections. So this is Cochrane analysis looking at the use of antibiotics for common cold and acute purulent rhinitis, and basically it shows that there is no difference in giving antibiotics versus placebo, but in this children who receive antibiotics, obviously you do have the risk of developing allergies to these antibiotics, and that's another reason why the allergy service here is very, very busy, because we get referred many cases of suspected allergies to antibiotics when children develop rash with the medications. So you see this chart, which basically shows a linear relationship between antibiotic use and the development of resistance. The higher the use of antibiotics, the more frequently it is being prescribed, particularly if it's unnecessarily prescribed. You will find that resistance to these antibiotics will increase with time. So therefore, it is very, very important that we do try to minimize the use of antibiotics, except in cases where it's truly indicated. What's the drivers of resistance? As I mentioned, the inappropriate overuse of antibiotics is the main one. The easy availability of antibiotics over the counter in some countries can also drive this problem of resistance. And if we give subtherapeutic doses, then we are not effectively killing off the bacteria that again can cause antibiotic resistance. Okay, low potency antibiotics or frequent exposures to the same class can drive it as well. So how do we minimize the development of resistance is really the appropriate judicious use of antibiotics, and I cannot stress that more. And of course, vaccinations where that is appropriate, that is much better in reducing infections rather than trying to treat it when it occurs. So antibiotics, it's a precious resource. We really do need to preserve it such that we have the antibiotics to give to these children rather than to have increasing antimicrobial resistance, which makes it very difficult for treatment of infections in the future. So if we not use antibiotics, do we have antivirals? And the only really effective antiviral is against influenza. The neuraminidase inhibitors such as oseltamivir and zanamivir can be given for influenza infections. However, it is not always that effective. In many cases, it is given for children with more severe influenza infections. However, you find that really it does not have a great impact on reducing the development of pneumonia nor the risk of developing otitis media and sinusitis. Okay, and there are side effects with these medications. So they have minimal benefit in alleviating symptoms, but there are risks of side effects. So vaccination is probably a much more better way of approaching prevention of influenza infections. So since we have really not much to offer when we are dealing with acute viral respiratory infections, hence complementary medications have become very popular. You have echinacea-based extracts, IV leaf extracts such as Prospan, polyherbal extracts such as Sinopret, and of course Pelargonium sidoides extracts, which is Kaloba, which is the topic of our talk today. So if I'm just to go through briefly some of these other herbal preparations, this is a meta-analysis of the use of Sinopret for acute rhinosinusitis. Sinopret is a polyherbal preparation made of a combination of various different flowers and roots. And when they looked at Sinopret, most of these studies were open label with no control, so therefore it's very hard to conclude the efficacy of the treatment. Symptomatic treatment was also allowed. So what you can conclude that it is very well tolerated, and I do see it being prescribed to children with acute respiratory infections, but probably better designed trials are required. Echinacea also has been touted to be very effective for upper respiratory tract infections. However, this study comparing it with placebo found that there was no difference when you're using it for treatment of upper respiratory tract infections. In this study, it was in children aged 2 to 11 years. Then IV leaf extract, also another very popularly prescribed medication for acute upper respiratory tract infections. There was 10 studies that were reviewed in this review, and all the studies included patients with cough of various diagnosis. 3 of these studies did include children only, 2 with only adults. However, the conclusion again was that it did result in reduction in cough symptoms, but it was very hard to effectively or conclusively conclude that it was effective because of various methodological flaws. However, most of these products are actually very well tolerated with very minimal side effects. So if you look at Kaloba, it's a proprietary extract from the roots of Pelargonium pseudoides, which is a plant native to South Africa, and that's the plant there. Okay, there it's indicated for the common cold, for bronchitis, for tonsillopharyngitis, as well as sinusitis. Okay, and there are various preparations available in Singapore. It's mainly the tablets and the syrup that's available, and that's the dosing that is recommended for children age 1 to 5, 6 to 12, and those more than 12 years of age. It has a threefold mode of action. It has antiviral, antibacterial, as well as secretory action on reducing the infections. And if you look at the antiviral activity of Kaloba, it acts by inhibiting the replication of most of the respiratory viruses by inhibition of neuraminidase. And it also kills intracellular viruses by improving the interferon beta synthesis in the host. So it therefore reduces viral replication and improves host defense mechanism. If you look at the in vitro antiviral activity of Kaloba on viruses, you'll find that it has a good inhibition of Coxsackie virus A9. It has good inhibition of influenza as well as para-influenza and RSV infections. Probably a little bit weaker for the human coronavirus, but it has no inhibition against adenovirus or, unfortunately, the rhinovirus type 16. So it also has antibacterial properties, and the antibacterial properties act by inhibition of bacterial adherence to the respiratory epithelial cells, and also inhibits bacterial internalization. So this is very nicely demonstrated here, looking at group A streptococcal adhesion to the respiratory epithelial cells, and you see that without the EPS 7630, which is the Kaloba preparation, there is good adherence of the bacteria to the cells, whereas with the EPS 7630, there's no bacterial adhesion. And if you look at the in vitro bacteriostatic activity, again, there's a dose concentration inhibition dependent effect on many of these viruses, bacteria. It also has mucociliary properties by stimulation of ciliary beat frequency of the respiratory ciliary epithelium that facilitates mucus transport and clearance of mucus from the respiratory tract. And in that way, it also reduces pathogen replication and their proliferation. So you'll find that with its combination of the antiviral, the antibacterial, as well as the mucociliary properties of Kaloba, it has some impact on management of respiratory tract infections. So if you look at the clinical effect of Kaloba in acute bronchitis in children, it shows a marked reduction in bronchitis severity score by day 7 compared to placebo, in that it gives a much more favorable disease course. And this is what is seen, that by day 7, up to almost 80% of patients that are given Kaloba for bronchitis have recovered, whereas only 20% of those receiving placebo had recovered by day 7. It is very well tolerated in children. It has a good safety profile, and it can be given to infants and children. So these are meta-analyses by different authors looking at the use of Kaloba for many of these respiratory tract infections in Taufikat. The first meta-analysis there that looked at 6 randomized clinical trials that were used for acute bronchitis. They showed evidence of effectiveness of Kaloba over placebo for patients with acute bronchitis. In Timmer et al., a Cochrane review looking at 8 randomized controlled trials in children. Again, in this, both adults and children who suffered from acute bronchitis, rhinosinusitis, and the common cold, there was efficacy seen with Kaloba versus placebo. And in Mathis, that looked again at 6 randomized controlled trials, a meta-analysis comparing placebo versus bronchitis again, common cold and rhinosinusitis. You'll find that there was efficacy. And I will go a bit more into the Mathis meta-analysis. Here they're looking at acute tonsillopharyngitis versus placebo, and you can see that it favors Kaloba in terms of reduction in the total symptom score at day 4, as well as complete recovery of symptoms by day 4 was much better with Kaloba versus placebo. Again, if you look at acute rhinosinusitis versus placebo, Kaloba at day 7 showed marked reduction of symptoms with complete recovery in the Kaloba group, much better seen than in placebo. And for acute bronchitis, both in children, adults, and adolescents, again, you'll find that there was efficacy in those receiving Kaloba versus placebo. Okay, and with many of these patients recovering by day 7 compared to the placebo group. So I've shown you today that upper respiratory tract infections are very common in children, and they're usually caused by viruses, and therefore antibiotics should not be given, though it is very frequently prescribed. Symptomatic treatment is our mainstay. However, it does not affect the or influence the duration of symptoms in many cases. And herbal preparations are trying to fill this gap. Possibly Kaloba may be able to do this because it has been demonstrated to have antiviral, antibacterial, as well as anti-secretory properties, which have been shown to be effective in reducing symptoms in acute tonsillopharyngitis, acute rhinosinusitis, as well as in acute bronchitis. Thank you.